Good morning, everybody. Welcome to another COVID-19 webinar brought to you by the National Institute for Occupational Health, the NIOH. The NIOH is a specialized division, a specialist division in occupational health within the National Health Laboratory Services and a sister institute of the National Institute for Communicable Diseases, the NICD. It's a pleasure to welcome you to this webinar. And our webinar is entitled today, Occupational Health Services for COVID-19 in the Health Sector. And today we are going to hear from the team that is from the HIV TB in the workplace unit here at the National Institute for Occupational Health. And we've got three good colleagues who's going to be assisting with the presentations here. Our first colleague is Dr Nkululeko Thunzi. Then there's Jonathan Ramodike, and then there's Professor Muzimkhulu Zungu, who's going to present on the three topics. And those topics are firstly by Dr. Thunzi, Hospital COVID-19, Occupational Services Readiness for the third wave in South African health facilities. And then we have Jonathan dealing with the HealthWISE tool or platform, HealthWISE COVID-19 risk assessment for the third wave in South African health facilities. And then we'll have the practical interventions for COVID-19 third wave in South Africa in South African health facilities, apologies, by Professor Zungu. So welcome. This is, I think, a very important topic. It flows logically from all the other webinars we've conducted since March last year. And it is particularly important to be focusing on an essential component within the workplace, particularly in the healthcare settings, and that is occupational health services. And we have three good speakers to deal with that. Just to apologize on behalf of Dr. Tanusha Singh. She is the head of the NIOH's Occupational Health Outbreak Response Team. That is the COVID-19 OHS team. She's unable to join us this morning as she has an important leadership meeting that she's attending, NIOH leadership meeting. But without further ado, we want to start with the program. Before we do that, just a few sort of virtual house rules. Please, I see there's two people who've already raised their hands. The hand raising function is not possible unless the speakers and time permits it towards the end. If a speaker, one of our presenters may want to clarify a particular question, that might be possible towards the end, depending on how much time we have at the end. But for now, please do not raise your hands. The two functions that is very important for you, the first one is the Q&A, the two speech bubbles at the bottom of the screen. Please click on that Q&A box and type your question there in the Q&A box. Our presenters will, when they are not speaking, address your questions in the Q&A box. The chat box, the single speech bubble at the bottom of your Zoom screen, is the chat box. In the chat box, that's for general comments, admin questions, etc. And we will be attending to matters there. Please separate it. Do not type your questions in the chat box. Type your questions for the content of the presenters' presentations in the question answer box. With regard to CPD certification, for those who belong to professional bodies and is good standing with those professional bodies that have accredited our COVID-19 Zoom webinars, the CPD link and password will be circulated after the webinar within 24 to 48 hours. A general certificate of attendance will also be issued to everybody. We will be circulating a post-webinar survey for you to give comments on the webinar and to propose new topics. And the links to all the resources, including the recordings, the presentations of this webinar, will be uploaded onto the NIOH's website, and the links will be emailed to you. A reminder, our website is zero-rated by all of the major mobile service providers and an internet service provider. So if you go to all the very useful resources on the website, COVID-19 resources and occupational health and safety resources, you will not be charged any data. Having gotten that out of the way, Yes, you are welcome to this webinar on occupational health services for COVID-19 in the health sector and the healthcare settings. And our three speakers I've mentioned to you. Our first speaker is dealing with the topic hospital COVID-19 occupational service readiness for the third wave in South African health facilities. I think this webinar is very appropriate also, since we've also shifted between levels and there is significant concern about the increasing numbers that have happened in the South African context and our different provinces. So I'm going to ask Dr. Thunzi just to start sharing his screen, his presentation with us, and to check on his audio. There's two of our attendees, two colleagues, or rather just Betty Satekhe. If you could just lower your hand and type your question. If it's a general admin question, please type it in the chat box. If it is a question specific to the presentation slides and the presentation of the speakers, please type your question in the question answer box. Thunzi, yes, thanks. I see your screen is maximized. If you could just check on your audio, and then I will hand over to you, sir. If you could unmute your microphone.
Good morning, colleagues. Can you hear me, Ashraf?
Very well. If you could just stay close to your microphone, that will be great. And your slide is also visible. So by way of introduction, Dr. Nkululeko Thunzi is a public health medicine registrar here at the National Institute for Occupational Health. He is directly associated with the unit, the section that has organized all of the for this webinar, and that is the HIV TB in the workplace unit here at the NIOH. And he is also associated with the Sefako Makgatho Health Sciences University. And I, with that short introduction, ask Dr. Thunzi to proceed with the presentation. I hand over to you, sir.
Thank you very much, Ashraf. Good morning, colleagues. I'm Dr. Nkululeko Thunzi, working for NIOH and a registrar in Sefako Makgatho University, as my colleague have introduced me. Today, we're going to be talking about a very interesting topic, occupational health services for COVID-19 in health sector. So we're only going to be focusing on the health sector. So my part that I'm going to be doing hospital COVID-19 occupational health and safety readiness in the third wave in South Africa. My other colleagues, as I mentioned, my colleague mentioned that the second colleague will be presenting on the HealthWISE COVID-19 risk assessment for the third wave in South Africa. And my professor, Zungu, will be doing the practical intervention for COVID-19 for the third wave in South Africa. Without waste of time, colleagues, we'll start. As we know, that we've been in the pandemic now. This is, we are in the middle of the second year, and the pandemic is still with us. We know that following the severe acute respiratory syndrome, coronavirus 2 SARS-CoV pandemic, as part of the protection of health workers, employers, and health sector are expected to activate their infection prevention control and OHS system in order to protect the health workers from SARS-CoV-2 infection while at work. As we know that this pandemic has been with us, we've been trying all the means to do, but the fact remains that the employers, especially now in this topic that we are talking about in the health sector, that they remain have that duty to make sure that they protect their health workers from the SARS-CoV-2 infection. And they need to mobilize their programs in infection and prevention controls, as well as enhance their occupational health and safety system to make sure that these health workers are protected, as we know that these are the foot soldiers, that they are first in line in fight with this pandemic. Without delay, I will first just give you some information that I think it will be very important that we note so that we understand why we had to do this survey that we did. So we know that there's been some concern of occupational health and safety in the health facilities. One of the recent studies that was done, it showed that the Occupational Health and Safety Organization and implementation has been in suboptimal levels in the Southern Africa. Study was done by Moyo and his colleagues, and they realized that the standards were a bit suboptimal in this regard of occupational health and safety. And to add on that, we also realized that the COVID-19 pandemic has shown some gaps in the health and safety of health workers with respect to prevention of COVID-19 infections and protection of health workers. And one of the prominent things in these gaps was conducting risk assessments, provision of personal protective equipment, care and support for affected and infected health workers, and lack of appropriate psychosocial support. These two components, they are very important and they tend to be ignored most of the time, especially the care and support for the affected and infected health workers. In terms of the care, we find that most of the time when the colleague is being infected, it's usually that the colleague would be advised to go and isolate and all that. But usually in that process, there's very little that is done until the isolation period is finished, and then we are expecting the colleague to come back without knowing how is the colleague affected psychologically and how much of psychological and psychosocial support that the colleague needed during that period, even when he's supposed to return back to the workplace. So I think that's one of the things that I think they are very important that we need to rectify to make sure that the infected and affected colleagues, we make sure that they get the best care while they are in isolation. And then we make sure that they also get the psychosocial support so that when it's time for them to return to work, at least they are well prepared to come back and soldier on. And as well as we noticed that there is lack of governance structures such as health and safety committees, as per the Occupational Health and Safety Act of 85 of 1993. And this is very important to committee to have in terms of dealing with COVID-19 in the workplace, because if you don't have these structures, and even though you have occupational health and safety, it tends not to function well. So you need to have the services as well as committees that are supporting all that, so that you can have everybody involved, including management, organized labor, as well as the occupational health and safety professionals. So we have done a cross-sectional survey in 4 hospitals in South Africa, and these 4 tertiary hospitals were chosen in 2 provinces, and we focus more on the occupational health and safety coordinators and occupational health nurses as well as managers. And we use the convenient sampling, and we wanted to target the hospitals that have more population of health workers. As you can see that the hospitals that we assess, they have a population of around about 14,743 health workers that they are in there. And we use a structured questionnaire to make sure that we gather the information that we needed from these occupational health and safety coordinators and nurses and managers to get a clear picture of the occupational health and safety services in these 4 hospitals in different two provinces in South Africa. So to go straight to what we found when we're doing this survey, We first looked at the policies and governance in these facilities, and we looked if the hospitals, if they had occupational health and safety policy. As you can see, all the hospital, at least they had all these policies in place. And we further looked if are they managing to break them down to make sure that they have standard operative procedures. And on that regard, some hospitals, they fell short. Half of them, they couldn't produce their standard operative procedures. And we further looked if the occupational health and safety, to whom does it report? And we found that 3 of the facilities, their occupational health and safety was reporting directly to the CEO, and 1 facility that it did not report to the CEO, because we know that CEO is an accounting officer, so it's always good to have the occupational health and safety services reporting directly to the accounting officer, which is the CEO. And we further looked at the communication from this occupational health and safety department to the management in terms of IPC and concerning COVID-19, how frequently they are communicating in terms of the information that they are getting on the ground, so that the management of the facilities can be aware of what is going on in their staff. Only 1 facility that they were saying that they said they were doing that once in a month. We were not happy about that, because as we know that COVID-19, the things can change very quick. And when you are dealing with COVID, you need to make sure that you are very interactive, because it's like we are dealing with a moving target. So it's very dynamic in the situation. So 1 hospital said that they were even doing the daily communication, which is very good. Even the weekly as well is still good, because at least there's a lot that can be done in a week's time if there's any agent things that needs to be done. We further looked at the health and safety committees. As I mentioned initially, that these are the structures that they support all the protection of the health workers, and this is a structure that contains all the majority of the people that are in the workplace, management, trade unions, as well as workers themselves. So it's a very important structure, which is even contemplated in the Occupational Health and Safety Act, and it's in the section 19, and where they say that each and every workplace, at least if it's got more than 2 health and safety representatives or more than 50 health workers, that at least they must have a health and safety committee. They must form that committee that's going to be able to be in the workplace. And in this regard, we looked at if the hospital, do they have an agreement with the organized labor on the nomination procedure for health and safety representative. And majority of the hospitals, they did that and they did have that agreement. Only 1 facility that did not have it. And we further look if the hospital, they had adequate numbers of the health and safety representative to employees. And we found that all of them, they did. As you can see, the following statement where we're talking about the ratio. To clarify the part of the ratio, according to the Health and Safety Act, it says that all the workplaces, or it says that workplaces like shops and offices, at least they need to have 1 representative for every 100 employees. And says all the other workplaces except offices and the retail shops must have at least 1 rep per 50 employees. So if you look here, the ratio is one, the first facility is 1:39, and which is the biggest ratio, and others is even lower than that. So which means that all these facilities, at least they have enough health and safety reps. So we further look if the representative, the safety and the health and safety representative, if they were appointed in writing, and all the facilities, at least they show the proof, the proof of that. They showed us the appointment letters. And we further look if the health and safety representatives have been trained on their duties. As we know that in the Health and Safety Act, there is a section which is section 18.1, where it describes the functions of health and safety reps. So at least when you appoint these people, as we said, they're supposed to be appointed formally in writing. So you also have a duty to make sure that you train them so that at least they understand their duties. So we looked at that, and unfortunately, 2 of the facilities, they didn't have the training, and the other 2 facilities, at least they have the training. And we further looked even to see how many were they trained, so that at least we can have a proportion to say at least the majority of them have been trained or not. Unfortunately, even on that regard, even the ones that they have training, they have trained even less than the 50% of their reps. So one facility that they said they trained them, they didn't have exact the number of how many they've trained. And the only facility that had the number, it was 20. And in that facility, they have around 47 reps. So if they have 47 and they only trained 20, it's even less than 50%. So we further looked at the health and safety appointments. If the health and safety committee appointment in writing in the hospitals is, and then in this regard, the committee, the health and safety committee were appointed in writing in most of the facilities, except one facility that they didn't have the proof. They said they appointed them in writing, but unfortunately they couldn't show us the proof. We further look at if the health and safety committee, at least it meets once in every 3 months. And we wanted to check if they had any records of minutes in that regard. Most of the facilities, at least they have that. Only one facility that could not have a proof of doing so. And we further checked if the chairperson of the Health and Safety Committee, was he appointed or she appointed in writing. Majority of the facilities didn't have the proof. Only one facility have the proof of that appointment in writing. We further looked at the health risk assessment, and as we know that the consolidated directions on occupational health and safety measures in certain workplaces, the latest version that has been published, I think on the 28th May of 2021 by the Minister of Labour and Employment, His Honorable Thulas Mercy. It says that the employers that employ more than 50 employees must submit a record of its risk assessment together with the policy and amendment concerning the protection of health and safety of workers from SARS-CoV-2. So it states clearly that during this pandemic, at least whoever who is employing more than 50 employees must have a risk assessment of their workplace. So we looked at these facilities, if in the last 2 years, if they had the occupational health and the health risk assessment as per the Occupational Health and Safety Act of 1993. All of them, at least, they had the risk assessment done. And then we further look if the risk assessment was it amended to include COVID-19. As I was saying, that the directions, they said at least your risk assessment must also address the the SARS-CoV-2. So all of them, at least, they managed to amend their risk assessment to address the issues of COVID-19. And we further look at the proof of evidence of this risk assessment, if they have any documents that they can show us, and all the facilities, they have those documents. And we further looked if the health risk assessment was approved by the CEO. As we initially said when we were talking about governance, that the CEO is an accounting officer. So if they are doing a risk assessment, at least that risk assessment must be shown to the CEO, and the CEO must approve it. Only 2 facilities that they did not have that proof of the CEO signing their risk assessment, which is not good at all. And we further look if the risk assessment was approved by the Health and Safety Committee. As we said, that the committee should work hand in hand. And only 2 facilities that in one province is that they have that approval from the Health and Safety Committee. And the other 2 facilities in the other provinces, they didn't have it approved by the Health and Safety Committee. We further look at the risk assessment if was approved by the organized labor. As we said, that organized labor should be participating in all the processes. Unfortunately, in this regard, all the facilities, they didn't have that proof of their risk assessment being approved by the organized labor. Then we further look if the summaries of health risk assessment was in each working area from the last 2 years. So which means whatever risk assessment that they are doing, is it distributed to the working areas? Unfortunately, half of them, they did not do that. And we further look at the occupational risk exposure profiles for different job categories and profiles, if they are categorizing them. Unfortunately, only half of the hospital were doing that. The other part, they were not doing that exposure profiles for different job categories. We further look at medical surveillance. We look if there was any active risk-based medical surveillance program at these 4 facilities. 2 of them, yes, they said yes, it was, and the other 2, they didn't have any proof of that. And then we further look if the percentages of the hospital, of the workers in the hospitals who had a medical surveillance done on them in the past year. So even though the other facilities said that they didn't have an active risk-based medical surveillance, but they show us some health workers that they had medical surveillance done on them. But unfortunately, the percentages were very low. The highest percentage that we could get of all in all the facilities was 18.6% of the health workers that received medical surveillance in the past year. We further look if the hospital conducting individual risk assessment to identify COVID-19 vulnerable workers. This is very important, that you need to make sure that your employees, you know their risk profile, who is more vulnerable than the others when it comes to COVID-19, so that you can make some arrangements so that you protect those vulnerable from getting infected. So only 1 hospital that did not have that in place. Majority of the hospital, they have it. We were happy with that. And then we looked if the health workers were screened for COVID-19 related symptoms before each shift. This is very important to make sure that you screen everyone before they start their shift. All the facilities, at least they were doing that one very well. Then we looked at the occupational health and safety trainings in these health facilities. We look if the health workers received any training on how to protect themselves from occupational hazard. All of the facilities, at least they have done that. They've done well. We look at the nature of the training. was it in-person training, and majority, all of the facilities, they said yes, they did in-person training. And we looked if they had any other means of the trainings, e.g. like training that are sent, like you send a document via email. Only one facilities, at least, that was doing that. Other facilities, they didn't have that in place, citing problems of the IT issues. We further look at if there was any other training that is done, like online training, like one what we are doing now, like a Zoom or Teams. Two facilities, at least they were doing that, and other two facilities, they didn't have that opportunity of doing online trainings. We look if they do have any other means of training, like pamphlets and speaking posters, such things that can help to also educate the health workers. Majority of the hospitals were doing it, only one that was not having that. And we look at the nature of the training using other means, if there was any other means that they were using. And only one facilities that they said they also used a WhatsApp group where they put the information so that it can get to other colleagues. And others, they didn't have other means on that. And then we look if the training conducted on the regulation, there was any training that was conducted on the regulation for hazardous biological agents during the last 12 months. All the facilities, they said, yes, they have done that. We further inquire about the proof. They showed us the proof of that. We checked if there was any recent training of hospital infection prevention control relevant to COVID-19 control. All the facilities, they are doing very well on that, so they are conducting those trainings. And we further look if the other workers trained to, if the health workers were trained to perform the respirator fit testing, which is very crucial, because if you are using a respirator and you are not using it properly, it is good as not using it. So majority of the facilities, unfortunately, they don't do that kind of training. We look if the health workers were trained on donning and doffing of the PPE. This one, they were doing well, only one facilities that they did not have that type of the training. We further looked at the ventilation, as we know that the directions that I was talking about, the consolidated directions on occupational health and safety measures that have been recently published, they are strictly specifying that every employer must keep their workplace ventilated by natural or mechanical means, at least to reduce the SARS-CoV viral load in the working environment. So they are very explicit on that the workplace must be well ventilated in whatever means. It can be either natural ventilation or mechanical ventilation. So we looked at this aspect. We look if the hospital, they have adequate natural ventilation overall. Two facilities, they were struggling on that natural ventilation due to the structural problems that they have. You will find some other hospitals, they were created only for mechanical ventilation. Now, if the mechanical ventilation is not there, you find that the ventilation is very poor in the facility. So we further look if the mechanical ventilation was there, if they have it. As you can see, there's one facility that did not have it, and other three facilities, they have them. But having it does not necessarily that you are on the good note. Hence, we had to further inquire if these ventilation systems, were they present and functional. And you can see that even though three facilities, they had them, only two of them, they have the functional mechanical ventilation. The others, they did not have, the other hospital did not have a functional mechanical ventilation, even though it was there. And then we looked if there was any, if there was a functional fans in place to help the ventilation. None of the facilities had that in place. We further look if there was a functional air conditioners. Only two facilities have that in place. We further inquired that if they had functional air extractors in place, which is very crucial when you're using the mechanical ventilation, that the air that is dirty is getting extracted out of the working environment. Unfortunately, only one facilities have that one functional. If I look at the PPE, we look if does the hospital provide the following PPE. Look at surgical mask, all of them, they were having surgical masks. N95, all the facilities were having that. Gloves, latex and non-latex, all the facilities were providing that. Look at the overgarments, all the facilities, they also have that. You look at the face shield, they have that. Then when it comes to disposable aprons, 2 facilities did not have it. And as well as when it comes to caps or health protection, half of the facilities did not have that. Then we look at goggles, only 1 facility was able to show that they have goggles in place. We look if there's a system if there was a system for allocating PPE to staff in each unit. All of them, they have the system in place of making sure that all the units, they have the necessary PPE. And we look if there were different sizes of PPE available. All the facilities that they had the different PPE. This is one part that sometimes many people, they don't focus on it, even if the facility does have different sizes of PPE. People, they don't pay more attention on it. Like if you're using a respirator, if you have a small face and you are using a respirator that is size large, it might not protect you properly. So it's always crucial that you make sure that you know your size, as well as the facility where you work, they provide different sizes. We also look at if the health workers, are they getting trained in respirator fit testing. And unfortunately, 2 of the hospitals did not have that program of respirator fit testing. They did not have that program in place. And as I was alluding in the previous question, that this is very crucial that the health workers, you can provide them with the PPEs, but if they are not able to use them properly, at the end of the day, the protection that you invested buying the PPE to protect them, it becomes fruitless because they are not protected. So it's very crucial that all the facilities, they have this fit testing program so that everyone knows how to fit their. So discussions with the results that I've been showing you colleagues, you can see that the health and safety committees were in place in all the hospitals, even though in the most of the hospitals, they did not have appointment letters for the chairperson of the committees, and some health and safety reps not trained in their duties in the majority of the hospital. As I was saying, that it is very crucial that if you have the committee, at least they must know what they are supposed to be doing. We further look if the health risk assessment are done across all facilities, and the challenge of approval by the CEO and health and safety committees. There you can see that most of the facilities, they did not have that approval, especially with the health and safety committees. And there was none when it comes to approval by trade unions or labor approval. Ventilation is still a big challenge in most of the facilities, even though we are in the 3rd wave of the pandemic. Seemingly few interventions were done to improve the ventilation since the past waves of infection, which I think this needs a very urgent attention, because if you don't have good ventilation, your staff is not well protected and they can easily get infected. Whereas if you have good ventilation, at least the viral load gets decreased in the working environment. With PPE provision was good across all the facilities and provinces. So there wasn't any complaints of lack of PPE. So I think this one of the things that I think I can applaud to the provinces, that at least they improve. It's no longer the same like when the pandemic started, where there was a lot of complaint of the provision of PPE. So at least that one they've improved a lot. All right, colleagues, from here, I think I will hand over to my colleagues. My part is, I'm done with my partner. Thank you very much.
That was Dr. Nkululeko Thunzi, Public Health Medicine Registrar based here at the NIOH and linked to the Sefako Makgatho Health Science University, now Health Sciences University, apologies. And Dr. Thunzi has dealt with hospital COVID-19 occupational health services readiness for the third wave in South African health facilities. Thank you for that, Dr. Thunzi. Just a reminder to those who want to ask questions on the presentations, please type your questions in the question answer box. Dr. Thunzi and colleagues will be looking at the questions in the question answer box and answer those for you there. If you've got general comments or general questions and admin related matters, please use the chat box. Do not raise your hands. I will be lowering your hands. Our next speaker is dealing with HealthWISE COVID-19 risk assessment for the third wave in South African health facilities. And that is going to be presented by Mr. Jonathan Ramodike. He is a Master in Public Health candidate based here at the NIOH and the School of Health Systems and Public Health at the University of Pretoria. I'm going to ask Jonathan to share his slides and to check on his audio. And by way of introduction, Jonathan Ramodike is a research administrator for the HIV TB in the workplace unit at the National Institute for Occupational Health, the NIOH, a division of the National Health Body Services, as I've mentioned. Jonathan is also a public health master's candidate at the School of Health Systems and Public Health at the University of Pretoria. And whilst we wait for Jonathan just to share his slides and to check on his audio, there was one attendee that had an audio issue. I think it's been fixed, but also just to say that the presentations and video and audio recordings will be uploaded onto our website, and the links will be shared with all of our attendees who are confirmed on our Zoom attendance register. Jonathan, I see that your microphone is open. If you could just use the green button at the bottom of your Zoom box to share your screen and to maximize your slides.
Ashraf, okay. Can you hear me?
Yes, I can hear you.
And can you see my presentation? Are the slides changing?
No, not yet. You've got to share them. So if you could click the green little icon at the bottom of your screen, there you go. And if you could maximize, I can see your PowerPoint layout, but if you could, there we go. So Jonathan, thank you very much. I think you're ready. I'm handing over to you, and that's Jonathan Ramodike, Research Administrator for the HIV TB in the Workplace Unit here at the NIOH. I hand over to you.
Thank you, Ashraf. Good morning, colleagues. As Ashraf said, my name is Jonathan Ramodike. I'm the Research Administrator for the HIV TB unit here at NIO. And I'm also a Master's of Public Health candidate at the University of Pretoria. And today I will be presenting on HealthWISE COVID-19 risk assessment for the third wave in South African health facilities. Okay. In terms of the methodology, it is very similar to what Dr. Thunzi has already presented. But for this HealthWISE part, the study design is a participatory action research, meaning that the level, it contains very high levels of participation with As there you can see on the population setting, the second point, there were HealthWISE experts. These were the people from NIO and UP, which is Dr. Thunzi, Prof Zungu, and I. And we were working together with the health workers from the 4 hospitals, as well as the trade unions. And if you look at the bottom there where it says data collection tool, that is another unique feature of this particular component. The first one is the HealthWISE checklist. And I will get into further details of that. And then the second one was a qualitative observational HealthWISE risk assessment, whereby us and the participants in the respective hospitals would go around and look at the control measures that will help, reduce the risks of getting COVID-19 in the workplace for the health workers. Now okay. So HealthWISE, basically, in summary, it is a tool. The keyword is tool. It is used to encourage workers and managers to work together to improve workplaces, health and safety in the workplace using low-cost solutions. This particular tool is developed by the World Health Organization and International Labour Organization. It's freely available online. You can Google it up. You just write HealthWISE and then ILO, and then you can download it for your particular interest if you want to familiarize with it more. We used the action manual, which is for the implementation of the program, the booklet on the left. And the module that we used is module 3, which is biological hazards and infection control, with special reference to HIV and TB. But now it was revamped to talk to the current pandemic, which is COVID-19, and had components of TB as well, because of the double burden of COVID and TB in the hospitals. So, as I said initially, the first thing we did is we used something called a checklist. Now, the checklist was to get an idea of the perception of the health workers in the respective workplaces that we visited, which was the entrance of the health facilities, casualty, outpatient department, and COVID-19 wards. So we would go there and then we would talk to the workers there and find out if they felt protected from COVID-19 and TB. So we just went there, introduced ourselves, asked them questions to understand before we engage further in working with them. Like we said, HealthWISE, it's supposed to help managers and workers work together. So we can't just go there and impose what we want to do. We also want to have an understanding of what the health workers in their respective departments are saying, so that we also reduce the chances of missing out on a few things, because definitely we will learn a thing or two from them, even though they are not occupational health and safety or HealthWISE experts. And from the checklist, the questions that we asked, you will see them on the left here. We went to, when we were at the security at the entrance, the questions that we asked, for instance, the first one, is there a routine to identify and assess biological hazards at the workplace? So basically here we wanted to find out if there was a risk assessment conducted for their workplace. And we didn't use the same language as indicated on the left, because before that, we would discuss with the people we are working with in that particular health facility. And we sort of translated the questions to a way we thought that the health workers in that particular area will understand. And you can see the picture is not all green. You know, there were some concerns when we asked the question. Some health workers did not feel protected. For instance, with question number 1 and hospital B, they thought that they needed better screening, you know, process improvements, and then they felt deficited in terms of surgical masks specifically. But again, these were just the findings, what they were telling us. And then on question 2, most of the people thought that they did have measures to prevent and control for droplet-borne infections such as COVID-19. Only one of the departments, one of the hospitals, sorry, said that they didn't feel so protected, and they thought that it could be improved in terms of social distancing and reviewing visiting hours. And then on the last question, we asked them if they thought that they had a comprehensive workplace COVID-19 and TB prevention and care program implemented. 2 of the facilities didn't feel that way, you know, at the entrance. This is still at the entrance. And they thought that this could be improved with visuals, you know, health information things. They would like more training and guidance. And then now we are moving to the outpatient. These are the findings we found at outpatient. We asked the same questions, and then you can see with regards to the first question that talks to risk assessment, when we tried to ask to probe them into telling us if they felt that they had such a routine, 3 of the hospitals said no, you know, which is quite alarming. And some of the things that they thought that could be improved is, again, you see a repetition of the screening. People were complaining about space, you know, I mean, it's outpatient. It's usually very, very congested, and they did notice that. So social distancing becomes a challenge. And then for hospital C had a problem with cleaners. They did not feel like the area, you know, outpatient was clean enough. So they proposed that the cleaners could work maybe during the night shift more. And also they did not have hot water. And the middle part where we ask about measures to prevent them from COVID-19, all of the hospitals felt that they had adequate measures. But this, again, this is what they are saying. It's not what we observed. We'll get into that a bit later. And then the last question, when we asked them about, you know, a comprehensive program implemented, only one facility felt like they did not have a program. The other 3 felt like they had a comprehensive program. And the suggestion from the one facility that said they did not have, they suggested that they should have more education as well as counseling, because, you know, most of the patients were dying. And then the findings from casualty, more or less the same. You can see there's some parts which health workers are comfortable and some are not. For risk assessment, for the facility that's felt like they did not have such, they didn't know what suggestions, you know, what proposed improvements can be done in that area. And then in terms of preventing them from COVID-19 hazards, it's more similar to outpatient, where, you know, crowd control was what they deemed to be a significant problem there. These were just the things that we recorded that they said. And then they were also having problems with masks. They felt that they had inadequate masks. And in terms of the program, the COVID-19 and TB program, two facilities felt like they did not have comprehensive programs. It was actually saddening, like in Hospital B, they felt like, they don't even feel a need to test or, per se, control for these things, because they felt that they were too exposed in that area. Whereas Hospital C couldn't even think of any proposed suggestions, even though that they felt that they were not protected. And then the last area that we went to, the COVID-19 ward, the health workers there said, with respect to the risk assessments, that they were not protected. And they focused on a particular work procedure that they did not feel safe with, which was specimen taking process of work inspection. And then the other ones, they felt that risk assessment was conducted in the area, except for Hospital C, whereby they thought that it could be improved by more in-service training. Again, on the second question where we asked about the COVID-19 measures to prevent them from COVID-19, they felt like they needed more fumigation, routine fumigation. We will talk about that one in the conclusion. And then the last part was, again, similar for the last question. They did not feel like they had a program, a comprehensive program for preventing them from COVID-19 and TB. Now, in general, how we summed it up is we thought that there was inconsistencies, in what people are saying, and we got the impression that most of the employees did not really understand the questions we were asking, and even their input would be very minimum, or they would inform us of something that is slightly out of topic. So it shows that there's a gap in the understanding of employees in terms of ways they can protect themselves from COVID-19 and TB to some extent. So this led us to our next step, whereby we conducted the qualitative observational HealthWISE risk assessment. This is the one where we actually went to look and observe ourselves, what is happening in the working areas. And the guidance we used was, some of you might be familiar with, the prevention hierarchy of control. And as you can see on the top there, it has the most effective control measures, which is elimination and substitution. And unfortunately, in this case, we did not look into those factors because they are not applicable. You cannot eliminate or substitute COVID-19 as of yet. So we were looking at engineering controls, administrative controls, and PPE controls. And our findings now from the walkabout, the observational study, where we actually went there and checked. On the left are the questions that we were, asking ourselves and trying to observe to see if we see people are complying or not. And straight off on the table, you can see from our legend that there's a lot of red color, which is very, very worrying, and this is at the security. So the first question was, are the staff social distancing? And only one of the facilities we observed that the staff are adequately social distancing. And we measured this based on if we thought it was possible for the staff to social distance. Because in some circumstances, we do understand that, the environment can make it quite complicated to achieve this to a maximum, but we said, we based this based on our judgment, seeing that, okay, something could have been done for staff to social distance. And then the second question was, are there posters or information leaflets about COVID-19 in none of the hospitals? We saw that at the entrance, and some of the reasons were, for instance, they were using the windows as to put what do you call these, posters, so they couldn't, I mean, we did not find, sorry, any of the posters in that area. And then the third question was about furniture positioning and social distancing. We also did not observe any of these things from the health workers there. We also looked at water and soap to clean hands, and only one of the facilities we did see that there was both soap and water for the employees to wash their hands. And sanitizers, if they were strategically placed in entrance and exit points, again, only one of the health facilities we observed that. And lastly, when in terms of waste segregation, here at the entrance, we only looked if there was a mechanism which separated the masks, like the surgical masks, from the general waste, because it is a biological hazard. So we were just looking for a box that people can go and dispose of their mask, and we did not see them in any of the hospitals at the entrance. So again, these things, like we said, health-wise, it looks at minimum resource solutions, and all of these questions here, they are not very difficult to try and achieve. It's mostly like behavioral or maybe negligence, but you don't need like rocket science or a lot of monetary funds and human resources to try and achieve this, but still they were not being done at the entrance. And then when we come to the ventilation at the entrance point, we found that all of the 4 hospitals, ventilation was inadequate. Was adequate, you know, in the outside area. But if you look at the security guard rooms, usually they're very small, congested rooms with minimum space. Most of the windows are closed. So it was, the ventilation there was quite worrying. And also they did not have mechanical ventilation in the guard rooms. So yeah, it wasn't very nice there. And in terms of the PPE that the staff were wearing at the entrance, this is what we observed. So in all of the 4 hospitals, they were wearing cloth masks and surgical masks. But then if you notice that we did put red there, so it shows that we are not happy with it. And the main reason is that because of the TB burden in hospitals, and statistics, they do show us that health workers are 3 times more prone to get TB than the general population. And TB is actually an airborne disease, and as in opposed to COVID-19, which is droplet-borne. So ideally, the best way for them to have maximum protection would be the use of N95 respirators, because you don't know by the end of the day who has TB and who doesn't have TB in such a high-risk area such as the entrance. Henceforth, on the N95 respirator, where we saw, yes, we equated it to green. So we would have been happy if we saw everyone wearing N95 respirators. And another unfortunate thing that we observed is that health workers were not wearing PPE properly. Either they would wear it under their nose or under their chins. And yeah, that compromises their health. And then now we move to casualty, the casualty ward. In terms of ventilation, Hospital A, the ventilation was inadequate because of infrastructural reasons. Yeah, they allowed very limited natural cross ventilation, and they did not have extractors, to remove that dirty air from the casualty ward to the outside. But the air conditioners, they were working, but now the problem is you need a mix of cross ventilation and air conditioner to adequately move the air in and out. And then Hospital B, the ventilation was adequate. They were using mechanical ventilation, as in extractors and air conditions simultaneously. So that was a good observation. Hospital C, it was also inadequate. The extractors were not working, and there was no natural cross ventilation. Hospital D, it was adequate. Even the extractors, we tested them. We used a simple test. We used the tissue test. We put the tissue on top of the extractor, and then it got sucked, and we deemed it adequate. But we also advised the facilities to, get someone like an occupational hygienist so that they are, very sure in terms of where they stand in terms of ventilation. Administrative controls, again, you can see it's also a bit worrying in casualty, whereby all of these variables that we talked about on the questions, we know that they're very easily manageable, but still there aren't practices to make sure that these mitigations are adhered to at a preferable level. And the difference between waste segregation here and at the entrance is we also looked at, if the sharp containers were also properly segregated into their own containers and not mixed with the general waste, and they're replaced in time, not overloaded into the waste container that they're supposed to be in. And also an additional thing that we looked at casualty is for the presence of COVID-19 waste management boxes. It was also worrying as only one of the facilities had waste management boxes specifically for COVID-19. The PPE that we saw staff wearing at casualty, you see the list is a bit longer because we expect more PPE to be used in casualty, is cloth mask. One of the facilities, we did find people wearing cloth masks and we were not happy. Again, for the same reason of the TB burden. This is casualty, usually congested, you don't know who comes with what. So we would have preferred if everyone was using N95 to protect them from COVID-19 and TB. Henceforth, in surgical masks, you can see that we did see people wearing them, but it's in red because it's not the optimal approach to try and reduce the risks of the health workers. The other PPE that we observed, it's just the findings. It doesn't mean that if we didn't see someone wearing it, like the overgarment, that they're doing something wrong. No, maybe at that particular time, there was no need for someone to use overgarments or overputs for their particular work process. But these findings, they can be used for other kind of questions that the OHS experts might have in relation to mitigating for COVID-19 in that particular area. And then the ventilation in OPD, hospital aid was inadequate. They did not have natural cross ventilation. The extractors were not working. It's quite alarming, like both mitigating approaches were not good. Hospital B, yeah, it was adequate. They were using mechanical ventilation, and we did test the extractors. Hospital C and D, in Province 2, the ventilation at OPD was not adequate. There were no windows, which inhibits natural ventilation, and then the mechanical ventilation systems were also not working in both facilities. Administrative controls in OPD, you can see very, very similar results to casualty. Most of these very doable things are not being complied. So, the overall, the take-home message is that it's quite worrying, and especially in such high-risk areas, OPD, casualty, entrance. And then again, the PPE that we found staff wearing at OPD, we get plus minus similar results where there is high use of surgical masks, even though we did advise and prefer them to be using N95 because, again, of the TB burden. The rest of the PPE observations are, again, quite similar, and just because we did not observe people wearing overgarments and boots at OPD doesn't mean that they're doing something wrong. It gives room to further scrutiny. Maybe the work process did not require such PPE. But we did see, people utilizing different types of PPE. And then now we move on to the COVID-19 ward. In province, I meant to write province 1 there. Province 1, in both the facilities, it was adequate. They were in hospital A, they were exclusively using mechanical ventilation. And we usually tend to use the simple test for the extractors, the tissue paper test, for both hospitals. So we were happy there. But also, these wards, they were fairly new. They had just reconstructed them. So, good things are possible if efforts are made to try and improve such conditions. In Province 2, Hospital C and D, unfortunately, the situation was not as good, whereby the ventilation was inadequate for both facilities. They did not have any kind of mechanical ventilation, and the infrastructure of the building or the ward did not promote natural cross ventilation as well. And this is a COVID-19 ward, so yeah, it's quite alarming there. In terms of administrative controls in the COVID-19 wards, we can start to see that there is a bit more green in the COVID-19 wards in all the 4 hospitals. It's still not perfect, but it seems that such control measures are taken a bit more seriously in COVID-19 wards. So, it also gives us an indication that these things are highly possible. It's just that the standards towards mitigating them, for whatever reason they have, are not consistent, or the same. Because of the differences in the good things and the bad things. And then the PPE, also the PPE that we found people wearing, again, we did not see anyone wearing a cloth mask, which has the least protection for COVID-19 and TB. And we were happy. That's why the no has screens. Unfortunately, for one of the hospitals, we did observe health workers wearing cloth masks. So that is very, very alarming. And shows that there could be like a serious gap there in terms of norms and practices. Surgical masks, we did not see anyone. That was very, very good. We were very happy with that because like we said, due to the double burden and then the maximum protection reasons, the N95 respirator is the optimal choice. And then again, with the other types of PPE, that is what we observed. On the overgarment for hospital A, it's quite, so many times you'd find employees wearing overgarments. We didn't see it, but they did have it. We did check. It's just that there was no work process that required someone to wear an overgarment during the day that we visited. Yeah, those were all the observations that we found, and then which led us to our discussion. The checklist, the HealthWISE checklist, the tool that we use to try and understand what is going on in the wards when we were talking to the people that worked there. It revealed that there are some inconsistencies in responses, as well as a lack of knowledge and practices. And in some cases, we found that there was confusion in the mitigating approaches for COVID-19 in the health facilities. Furthermore, the overall perception of the workers towards COVID-19 mitigating measures to reduce the risks in the working place was unsatisfactory, from their tone of voice, their actions. They showed concern and they were worried. So that's why we said it was unsatisfactory. The HealthWISE Qualitative Observational Assessment revealed that the ventilation was poor, as we saw. Administrative control measures were inadequate, although supplies of personal protective equipment were adequate. PPE was not often worn properly, like we mentioned, under the chin or under the nose. The overall results of the observation shows that efforts to protect health workers have been done, but they're very much warranted. There are issues that are worthy of worrying about, especially because they are very, very doable, using all the resources that are already present in the health facilities. And with that, I would like to end the presentation. Thank you very much. Back to you, Ashraf.
Thank you very much. That was Jonathan Ramodike, dealing with HealthWISE COVID-19 risk assessment for the third wave in South African health facilities. Thank you for your contributions. I'm going to, if you could just unshare your slides, I'm going to immediately move over to our next speaker, and that is Professor Muzimkhulu Zungu, who's the head of the division HIV TB in the workplace here at the NIOH. Professor Zungu is going to deal with the practical interventions for COVID-19 in the third wave in South African health facilities. By way of introduction, Muzimkhulu Zungu, that's Prof Zungu, is a public health medicine specialist with further training in occupational health. He is a joint appointment and an adjunct professor at the National Institute for Occupational Health, a division of the NHLS, as we've mentioned, and the School of Health Systems and Public Health of the University of Pretoria. He's also been previously been the acting executive director of the NIOH, director of the Medical Bureau of Occupational Diseases, and an assistant compensation commissioner in the Office of the Compensation Commissioner for Occupational Diseases, the CCOD. Prof Zungu is the current coordinator of the Diploma in Occupational Medicine and Health, that is the DOMH, at the School of Health Systems and Public Health at the University of Pretoria. He's a member of the National Occupational Health and Safety COVID-19 Committee under the National Department of Health. And with that introduction, thank you, Prof. I see that your slide is maximized. If you could just check and test on your audio. Thank you for taking the time to share your experience and knowledge with our audience.
Good morning, good day, Ashraf, and good day to our colleagues who are joining us online. I hope you can hear me, Ashraf.
Perfectly, sir. Please proceed. Thank you.
Thank you very much, and thank you to the colleagues for allowing us to share our rapid findings from the survey that we did in the past in this current wave of the COVID-19 in health facilities, as we continue doing operational research to try and work with the people at the health facilities to improve situation as and when we find that things are not going well. So I'm just gonna just share on my experience together with the colleagues that have presented this morning on what we think hospitals should consider as they manage occupational health and infection control in health setting, particularly with the plight of trying to save the lives of health workers. So we think that in this session, we will just want to discuss the rationale for occupational health and safety interventions following our experience working with COVID-19 pandemic in healthcare facilities since the beginning of the pandemic. I just showed this as I was preparing for this session from Wilson et al. That the health and safety of health workers is a global priority to prevent the collapse of the healthcare system, which is essential. I mean, I cannot overstress the importance of us needing to have a health system that works and functions during this time. But also, more than that, health workers are one of the 6 building blocks of a health system. So meaning that without health workers, we'll be unable to have a health system. And we know from reports coming from the NIOH that of the health workers that have been admitted to hospital, we've noticed that there's a very high rate of health workers who are dying. The latest reports that about 12% of health workers that have been admitted have succumbed to this disease. And we cannot afford to lose any more health workers because of this disease. But also, if we do not take care of our hospitals and health facilities, we create the potential to can have the infection transmitted from the hospitals to the communities. So it is very important that we have interventions that work. Of course, I'm speaking confidently today because we all know that COVID-19 in South Africa is treated as an occupational disease in line with the directive on compensation for workplace acquired novel coronavirus disease from the Department of Employment and Labor. And please, if we can just visit that so that we see who we need to submit so that we can first be able to keep the correct records and we can be able to have information for surveillance, but also to make sure that those who need compensation can be afforded such. This will also assist with managing the leaves associated with compensation. And many people do ask whether COVID-19 at work should be considered an occupational disease in the health setting or should be considered a workplace issue. And I think this directive answers this question precisely for workers in the health sector, especially because in the health sector, we know that people are exposed, but we know that people are exposed during the course of their employment. So we should take this very seriously. But when we're talking about what is it that people need to consider when they look at all the number of documents that are coming up from, the global space, WHO, ILO, and in some instances, people look at other countries like the United States and the UK, Australia, as to what is it that they are doing. And we also look at the African Union in terms of NEPAD and what they are saying we should do during this time to protect ourselves in the workplace, in health settings in particular. So there's a lot of information that's coming from there, of course, from peer publications, as well as information coming from locally, nationally. There's lots of policies that are coming out at any given time during this time, because this is a fluid situation that keeps changing. So we thought that for practical intervention for the people on the ground in the health facilities, it is always important to look at it from the point of view of these three parameters of looking at the agent, which will come with the source, as well as looking at the environment where you are working, and looking at yourself as the health worker, your state of health when you are working, but also understand the dynamic around the transmission of the virus, so that when you are communicating intervention in your workplace, they can target the areas where you think you have the most weakness, but also you can start with the low-hanging fruit as early enough so that you can concentrate then on the more difficult things like the environmental issues at a later stage. So this slide just talks to a few things that people need to be aware of, like what happens to the patient that presents at the hospital. For them to can be of high risk to yourself as the worker in the hospital, and what you should think about the number of, in terms of the viral dose that is produced by that particular patient that is coming into the health facility, but also the environment that you are working in. We saw quite a great deal from both presentations that have been done this morning on issues of ventilation, which has been reported as the most important parameter at this time for managing the pandemic. And of course, our responsibility as to what is it that we are doing ourselves as health workers to protect us as well as our co-workers, our patients and visitors in the health facility, but also our families when we go back to society and we go back home. So it is important to consider all of those things. Now, when we think about the source of infection, it is very based on the observations we saw when we went to the hospital. A lot of people, when they see a patient, as you see on the right, on the left of your screen, when they see a patient, they take serious measures because they think the person is very sick. But this on the right, the familiar side, where you see co-workers not taking precautions when they are communicating with each other. And we worry about this because this is quite a familiar sight when we visit these facilities. And this is something that is readily doable, especially for people who are outdoors. In some instances, when people are taking breaks, we think that it's something that is neglected that should be taken care of. Of course, the infection risk in healthcare facilities depends on a number of things, but we wanted to stress the issue of the fact that when you are working in the health facilities, you are more likely to be sharing space, and in many instances, space that is small with several people that you do not live with in your house. Those people could be the patients. When you are working with the patient as a clinician, you might spend a lot of time close to that patient and you have to talk to the patient as well. But also contacts which is greater than 1 meter is not always possible. Contact with one patient or more who is infected with COVID is highly likely when you're working in the hospital. So your chances of being infected increase because of that. The duration of verbal interaction, what we found as we were walking around utilizing the HealthWISE tool of the WHO and ILO, we found that at many instances, health workers are spending a lot of time talking to each other. And when they are talking to each other, that's when their sense of security is falsely reassured, and they are likely to not take measures because, one, they would not be social distancing. Two, they will not be using their PPE properly. So which are things that we can observe as we walk around the facilities. But there's also an issue in when health workers are taking breaks. Many of our facilities do not have proper facilities for health workers to take a break. They end up being in rooms that are at the back of the working area that are usually small, and that's where people take a break to rest. That's where people have lunch. That's where people have tea. And you find that there's a lot of congregation in those rooms, and usually those rooms do not have great ventilation also. And in such instances, a lot of people are also not wearing their PPE when they're in those rooms. So we worry about that. And some people, of course, travel together in transport coming to work. So that maybe another issue that people should think about when they're thinking of what interventions they need to be maintaining when they're relating to work. Of course, the severity of the patients that you see does have implications for the risk. Now, I'm sorry about this slide because it seems to be talking a lot about transmission, especially airborne. But the reason that I put this slide is because we are all aware and we all know that at this point, WHO, as well as the South African authorities, including the National Department of Health and NICD, have provided us with information that we need to take droplet precautions, in particular because the COVID-19 virus is transmitted through droplet spread and for mites, of course. And in special conditions in healthcare settings, there'll be aerosol generating procedures, which will also cause transmission. In this case, it will be airborne. But I just wanted to raise that because we here are health workers and have got access to information, we should read around the information that is coming out from different researchers across the globe about airborne transmission of the virus. We have not yet received enough evidence to conclude that COVID-19, we need to take airborne transmission in health settings in particular. But for us here in South Africa, we have the problem of tuberculosis. It has been said that South Africa is the capital for TB. And if South Africa is the capital for TB, that means those patients with TB end up in our health facilities. And we have the National Infection Prevention and Control Guideline for TB, which advocates for taking airborne precautions when it comes to TB. And based on that, and based on the fact that in occupational health, we do a risk assessment, and the risk assessment has to take into consideration all the hazards, and our controls must be geared towards controlling all the hazards that are in the workplace. We think that there's a bigger role for the use of the respirator in certain parts of the health facility by specific health workers in line with the health risk assessment. What we're trying to caution against is just now that we are going through the pandemic, people just taking measures that are specific to COVID-19, disregarding other potential infections in the workplace. So that's what we wanted to urge. Hence, when you saw, when Jonathan was reporting, there's a lot of people, you walk into an emergency department, like the casualty, you find somebody wearing a cloth mask, you find another person wearing a surgical mask, and another person wearing a respirator, yet they are doing the same task. So it is important to try and communicate properly the risk assessment, which will guide what type of PPE should be worn in which setting. Now, as I have mentioned that in the first slide, that the environment is very important. While most buildings have a door and a window, in our health facilities, in some of the working stations, like the emergency room, you are unable to open the window. You are able to open the entrance, but you are not always able to open the window. So there is a big room for mechanical ventilation, because it then ends up as our last hope. So it is important that we've got appropriate mechanical ventilation. We notice that health workers are not always aware of what is ventilation, because sometimes health workers would have a fan, which is essentially responsible for cooling the air in the room, and they consider that as ventilation. So it is important that we communicate, as the occupational health people and infection control practitioners, communicate appropriately with everybody who is working in the healthcare facilities so that they understand. But more than anything, to communicate with the facilities management. In one of the facilities that we visited, we were trying to look at ventilation, and we were trying to assess if ventilation is there and adequate, particularly mechanical. Because the nursing staff as well as the other professionals in the particular ward we're in were unsure, and we used our qualitative methods of assessing, the smoke, or using the paper to check if there's any movement of air, which we struggled. So we went and called the person who's in charge of facilities management. To our surprise, even that person did not know. So which means that people just go around listening to machines in the hospital that make noise and assume that they are working when they are not really working. So it's important that we look at this, because in that particular facilities, it wasn't even 2 months since a service provider was there to install mechanical ventilation and had informed people that it's working when it wasn't actually working. Issues of hygiene in general, environmental hygiene and personal hygiene are important. Up to today, since the beginning of the pandemic, there hasn't been a facility, and I'm going to specifically talk about the emergency department, because most of the emergency departments that we go to are always full to capacity with no room for social distancing, no adequate ventilation. But we don't even also see any regular cleaning of the environment. We don't see the tables and that people sit on when they're talking to strangers and they're talking to visitors, when they're writing their notes, when they're making telephone calls, being cleaned. We don't. When we inquire, that happens once a day, if it does happen. So we are worried about that. We do need to find ways to reduce congestion. Our facilities are highly congested. I do not know if we're going to accept that there's a lot of burden of disease in our country, and as such, there's lots of people coming in, and we cannot have the people that enter at least the working areas, so that the environment is allowing for protecting the workers there. I think it's something we need to think about and find ways that are going to help us, and not just accept it as it is. It's something that we will live with. Now, I want to talk slightly about the role of leadership, and I'm gonna limit the role of leadership to management at the local facility, and I will not talk to national and as well as province, because they also have their responsibilities. But for today, our observation is that there is a lack of the culture of OHS in our management. And OHS is a secondary thought, if at all. And when it is a secondary thought, we find that our managers are preoccupied with compliance with what has to be sent above them. So they're more concerned with what has to go back to the province or the district or national, without knowing the impacts on the ground, on the workers in the facilities where they are. So if for example, somebody says, oh, we need to submit the list of people with COVID in the past week, that will be a priority. As to under which circumstances the people got infected, as to what can be done to prevent this from happening going forward, as to who are the stakeholders that can come into the facility and work with us and improve the situation, most of our managers seem to be lacking in that front. And we need to do more to get them to be more active in such. It does not seem to be, they do not seem to be engaging with OHS. I noticed on the chart, there was a colleague who was inquiring about why do we want the CEO, for example, to look at and approve the health risk assessment. It is precisely for things like this, because the health risk assessment is one of the main important activities and documents that would come out of that activity for managing OHS in a facility. And if the CEO is not aware of that and is not participating in making sure that the things that are recommended in the health risk assessment are being done, it is to the death of OHS and infection control in the health facility. Most of the health and safety committees that are active, we were very appreciative of what they are doing, but we're very concerned that a number of the health and safety committees, people get nominated and then thrown in the deep end, not being empowered as to why are they in that health and safety committee? What is it that they need to do? How can they help their co-workers to improve their working environment in the section that they are responsible for? So health and safety committee members, you'd find that they would put a nurse who is trained in occupational health, who's got a lot of information, and there will be a person who comes from another category of employment, which is much lower with less training, who is even intimidated by the words and the conversations that happen when, say, the occupational medical practitioner is coming to present something in the health and safety committee, and they end up being a spectator in such a vital structure for OHS. So we were very worried about that, because even in the meetings that we go out and we engage with these colleagues, we find that they come, they sit in the meeting and they leave. They have no opinion. And when you engage them further, you find that they are not empowered. They are not trained. They are not given the confidence to engage. So we are worried about that. And sometimes we get told that they're not interested in coming to the meetings, and it's been accepted that, our meetings will not go as much as we want because people will not attend. So we worry about that, because that's a vital structure, the Health and Safety Committee. Of course, we are under the impression that people, when they receive a policy that comes from, say, the National Department of Employment and Labor, we do not expect that everybody should just read the policy from national and understand it. We are of the opinion that the policy, when it arrives at the facilities, it must be translated to a language and to a scope that is acceptable and understood by the people on the ground. And one way of doing so is utilizing standard operating procedures for different things and activities within such. But in our facilities, we found that it's possible that in some instances, we had an occupational health nurse who was asking us, what is a standard operating procedure? What is it used for? So it worries us that such can happen. So it means that we do have a lot to do going forward. And of course, facilities do not have budgets for OHS. We are just grateful that some of the facilities, because of COVID-19 now, they have managed to get a number of human resources and a number of things we're able to do now because of COVID. But we are still very much worried of the silos. Of these four facilities, if only one facility had an infection prevention control coordinator working with us when we're looking at OHS issues related to COVID-19. That tells a story on its own, that there are silos at the facility level and people are not talking to each other. And of course, the ongoing infrastructure and equipment issues, this is not something that is generally, I would like to talk about the most, but what we have seen is that whenever there's an issue in the facilities related to infrastructure and equipment, there seems to be no proper consultation of the people at the facility by the people at the province. And this results in the facilities receiving tools that are not appropriate for what they need to do. But also, there seems to be interest in, in buying things that are easily not under the control of the users, which is something we worry about this in the facilities. And of course, the lack of occupational health information systems. All the facilities we visited essentially do not have an electronic information system, or maybe rather I should say they are not using an occupational health information system, even the ones that have. So they're still reliant on manual, paper-based information, so which is worrying. But there's also a lack of using information collected at the facility. So information gets collected because it has to be sent elsewhere. It's not collected for decision-making at the local level. So those were some of the things that we worried about. And no sharing of information with the workers themselves. Dr. Thunzi presented in a slide about communication, and we had most of facilities saying they communicate weekly. But what we noticed, that communication is communication to management, not communication to the workers. So we are worried about that. So what we hoped to find in reality when we were doing this, is that we should have an OHS program that incorporates COVID-19. And this program should have a number of things. And I'm going quickly because I'm also conscious of time. But all the green things are things that we notice that are there, but the red ones are things that are not there. And we think that those things need to be prioritized. So regular cleaning of environment. I mean, it was somewhat disheartening to us to find a hospital with no water. And when we ask, yes, they do indicate that the municipality is the problem, but we get told that that is a problem that's been going on for 3 years. So the question here becomes, what then is the backup that the hospital has for the water situation? But also the lack of soap. Since the pandemic, sanitizers have replaced soap, and we don't think that's a good thing. And we think that education should be continuous. The role of vaccination is, we cannot overemphasize the importance of vaccination. And workers should be vaccinated. And we don't think it is at its optimal at this time. We, like I'm sure all of you colleagues, find that there's a lot of work we need to do in behavior change, because while we agree that the rooms were small, in some instances, people could not do social distancing, but you would find people who are not working, who are in a room having lunch, who are not social distancing. And when they're having lunch, they have food, they're eating, they are talking. We are worried. And of course, it means the hospitals have to work with the health promotion colleagues to try and promote OHS within the facility. While there is access to testing and treatment in the facilities, we are worried about the paying of lip service to screening. Everybody says we are screening every day when we get to work, when actually not anymore. I don't know whether it's fatigue, but there's no proper screening. Initially in the pandemic, people used to screen at the gate, but of course, logistically, that was impossible because of the number of people coming in and waiting outside and the weather conditions and so on. But it seems not to be working when people are saying they're screening themselves when they get to their ward. So something needs to be done about this and to find a way. Of course, issues of mental health, it seems like we are not really working very closely as OHS people with our colleagues at HR to make sure that we find access to mental health support. So based on our observation, we recommend more targeted but simple interventions on a continual basis, i.e. telling the workers to do everything at the same time is very difficult for them to be able to manage. So you have to find ways of communicating on a regular basis, but doing it simply and using language that the workers understand at all levels. So one of the things that we think should be adhered to is that we should try and develop SOPs that are going to explain these huge policies that are kept in every ward in a thick file that nobody ever opens except when somebody from outside is coming for either an audit or a survey like what we were doing. We think those files are not doing what they need to do. And we found that now, because of the quality assurance programs like the Ideal Clinic, people are no longer allowed to place posters everywhere, and there are no notice boards in some of the areas where you can strategically put information. So we do need to find ways of using standard operating procedure to relay information to people on an ongoing basis. Also, find ways of sending information not only through gatherings, because we know that COVID-19, if you look at this picture on this side, this may not always be the best thing to do. Some people have got access to computers and you can send an email. Some people have got gadgets, including cell phones, and we became aware that in most wards, there are WhatsApp groups that people are using for operational reasons, for shifts, but they don't use these groups to share information on OHS. And we think that this behavior must now be adopted to use these platforms to share information. Of course, consult with the communication department at your hospital as to which means of communication is the best. But we think that communication is one of the things that requires attention in controlling the COVID-19 problem in our health facilities. Of course, the ongoing problem with ventilation, I'm not going to spend time about it, but it needs to be attended to. Where you do not have mechanical ventilation, you should be utilizing natural ventilation if you have, and you should be utilizing the tools that you have to support the natural ventilation. Social distancing, I think I've touched on this a number of occasions. If you look at the picture on the left, these are colleagues who are not necessarily carrying out duties, but they were celebrating something. While they are wearing a lot of PPE, we think that it should be culture now to social distance, so that even when you do not have the PPE, you can still be protected. So washing of hands and cleaning the environment for frequently touched surfaces, we think all of these interventions that we have put up, including this one on PPE, we have shared with the facilities. What we are doing using the HealthWISE modules is that we send one of these slides at a time to different groups so that people can remember the things that they need to do. So working with the colleagues, Jonathan and Dr. Thunzi, they came up with the idea that we can call these hashtags Be HealthWISE when you're in your workplace, and share them and on a regular basis in the different social groups that we have within the workplace. So what we are trying to say, colleagues, is that we can't do big things at a go, but if we all do a little bit, we will be able to achieve more in our health facilities. Thank you very much, Chair.
Thank you very much. That was Prof Muzimkhulu Zungu, the head of department of the HIV TB in the workplace section here at the National Institute for Occupational Health. Thank you very much for your contribution. I noticed, Prof, that there is a Sududuzo Chabalala who had posted something for you in the Q&A box. If you could just perhaps just have a look at that. So maybe to start off with our other two colleagues first, Dr. Nkululeko Thunzi, as well as Jonathan Ramodike. You've answered questions in the question answer box, maybe a minute or two on the major questions that you've had to answer there that you may want to reflect on or emphasize in terms of your own answers and responses there in the Q&A box for our attendees. Dr. Thunzi, if you could just unmute your microphone and give us some input on that. In the meantime, I'm not sure, there is one hand raised, Prof. I'm not sure if you want to go and check if that person wants to engage with you.
Yes, we are happy to engage.
Okay, Louise de Wet, I'm going to provide you with the ability to contribute. If you could open your microphone, Louise. In the meantime, for Irene Tsitsikawe, the presentations, and we've told people already, will be uploaded on the website of the NIH. It's a zero-rated website, so you won't be charged any data or there won't be any cost involved if you visit our website. The presentations will be uploaded there, as well as the links to the video and audio recordings of today's webinar. I'm not sure, Louise de Wet, I've provided you with the opportunity just to either ask a question or make a comment. I see your hand is raised, unless that may be a mistake. So there is a comment by Tsabalala, Prof, directed to you. I've been observing the job specification by the facilities when they are advertising for the HSE management jobs in hospitals. Most of them require people with nursing qualifications. I'm of the view that this could be the reason why there is a substantial lack of structure in the HSE systems for hospitals. I'm not sure exactly what our attendees' skill set and background or profession is, but seems to argue that maybe there should be a broadening of who could be required to contribute to health and safety and environmental management roles within the institutions. Prof?
Thank you, and thank you to Studuzo. I think the reason for this is historical and also related to the fact that in health facilities, when occupational health was introduced in the public sector in particular, it was introduced primarily to do medical examinations, which of course is not the right way to go about when you are doing occupational health and safety, because we know that occupational health and safety is primarily dependent on primary prevention, which is preventing the disease or the injury before it occurs. And in order to do that, there are a number of other professionals other than nurses that are required for that part, which is the most important, of course. So because of this need and this thought by most of the health facility that OHS means doing medical examinations of workers, it was easy for them to go with a nurse, but also nurses being quite readily available in the public sector is probably one of the other reasons. We are, however, working with all partners to try and change the culture so that we all understand that occupational health and safety and environment is a multidisciplinary field, which requires different people with different expertise to do different things. So it is, of course, very difficult to come out outright to say who then will lead that team. But I'm sure individual entities can decide on this. And I certainly do not believe that just because I am a nurse, then it automatically makes me the person responsible for OHS. I have worked with nurses who've been in charge and it's been excellent. And I've also worked with people who are not nurses, but who've got another profession, and it's been excellent as well. Thank you.
Thank you very much for that, Prof. I just want to check if there are any additional comments that Dr. Thunzi or Jonathan may want to make based on the questions that has been there. And you can just open your microphone to make the additional contributions. I see Dr. Thunzi, your mic is open. Please proceed.
Thank you very much, Ashraf. Thank you, colleagues, for the questions. I think on my side, I can just say that it seems like the most burning questions that were on my presentation were on the consolidated directions. It seems like most of the people have not looked at them. So I think what I can advise that colleagues, if maybe we can go through them and check, because most of the things that they say that most of them, it's either they are from the Occupational Health and Safety Act, and they are very specific in the things that is supposed to be done. Even there was a question that was talking about the labor unions being involved when it comes to risk assessment. in those direction, it does talk on that. It says that it must be consulted with the organized labor. So for that thing to be documented, the organized labor should sign on that document and say, yes, it was consulted with us. So I think, colleagues, most of the questions from my side, they were more based on the consultation directions. So I think we need to have a look at them, and then we see what are the things, the latest things that we are supposed to be doing in the workplace. Thank you.
Thank you for that. Colleagues, there are two people, actually three now, who may want to just say something. I forget the sequence of the hands that I saw, but I'm going to ask Sipulele Motsamai just to open the microphone and make a comment, and please be brief. I see this one